So this work was mainly done by Fabrice Marquet and Pierre Bourg, who are respectively postdoc and a PhD student in our lab. Cardiac arrhythmias are the main cause of death in the world. And the most common known are atrial fibrillation and heart failure, and so sudden cardiac death, that is also ventricular fibrillation. And for those who are not really familiar with all the heart works, you have the mechanical contraction of the cavities is triggered by the propagation of the electrical signals that initiates in the sinus node, then propagate to the atria and then goes to the ventricles. And if you have, for example, recording points with electrodes, you can map this electrical depolarization of the atrium and the ventricle, which are delayed in time. Of course, you may have disease that affect the electrical conduction, and one can easily understand that if you have different conduction between for example, the right and the left ventricle, you have a mechanical asynchrony, and then you have a loss in the efficacy of the pumping function of the heart. Current therapy relies on the insertion of leads, and these leads are connected to a box that detects the electrical activity and sends electrical pulses to resynchronize the heart. However, there are a number of situations where you may have infection where the leads are inserted. You may also have a broken leads, and for these reasons, this is a preliminary study to investigate the possibility to make a non-invasive cardiac pacing using focused ultrasound. So the phenomenon has been described almost 1 century ago, and only a limited number of studies has been performed to study the impact of ultrasound, and mainly for the safety reasons for ultrasound imaging. And so to explore this, to develop this application, we designed the experimental setup that is displayed on this slide. So we developed a system that allows to have a beating heart from a large animal, from a pig, that you can see here beating. In this heart, you can insert MR-compatible catheters in the different cavities to record the electrical signals, and from these signals you can synchronize the HIFU pulse and the HIFU devices underneath the ultrasound. All this is made MR compatible, and you can insert this inside the magnet. The advantage is that, of course, you can use MRI to target the localization on the heart you want to sonicate, and you can use these electrical recordings to trigger the ultrasound pulse when you want into the cardiac cycle. If you apply this pulse, for example, in ventricle during this period, which is called the refractory period, you cannot induce any premature ventricular contraction. But if you apply this after this repolarization, the T wave, you can induce an electrical depolarization. And if you add, in addition to the electrical readings, you add a pressure sensor into the left ventricle, you can clearly see that in response you have an effective ventricular contraction. Of course, the question is, what are the sonication parameters that you must apply to ensure that you're, in 100% of the case, you're able to induce premature ventricular contraction. So the reference method is electrical stimulation, and you have here the voltage versus pulse duration. And if you are above this limit, then you ensure that you have stimulation, and otherwise you have no effect. So to draw this kind of curve, we made a number of experiments over 10 ex vivo beating hearts with more than 700 stimulation sites in different cardiac chambers, and we plot for different pulse durations and pressure. We plot here the peak negative pressure and peak positive pressure, and what we can clearly see is that around 1 millisecond you have a limit with 2 plateaux, which suggests that you have potentially different mechanisms of action. Using this, once you have calibrated this, you can, for example, use emit a set of ultrasound pulses, and what you can see from the electrical recordings is that if you apply this to the ventricle, then you capture the cardiac cycle, and you force the heart to beat at the desired frequency. Can you run the video, please? So this is the video. We're starting in the sinus rhythm. It's beating normally there. And then when you apply the ultrasound, you will clearly see that we're able to stimulate the heart at the desired frequency. But you can also do other things. For example, you can explore the electrophysiology. If you send now a single pulse, but very well synchronized on the repolarization on the T wave, you can make the heart go from the sinus rhythm to ventricular tachycardia. So this could be helpful to study the propagation of the electrical signals without having to insert a catheter inside the body. Taking advantage of the beam steering capabilities, you can also send pulses in over 2 different cardiac chambers, and by adjusting the delay between the 2 pulses, you can then adjust as you want the contraction delay between the atrium and the ventricle. These were many results in ex vivo, but we also try on 4 animals in vivo and pigs. So these are examples where you have the animal with 2 different slices of MRI. The problem is that we don't have enough pressure to reach the limit that we show on the ex vivo results. So to help, we injected a sonoview, and we were able, under these conditions, to induce a premature ventricular contraction. I'm sorry. We also make a first study on the safety assessment from MRI, gross pathology, and Mason staining, and we are not able to evidence the presence of damages. In conclusion, non-invasive cardiac stimulation and pacing is feasible on large animals, but further studies are required to better characterize the mechanisms depending on oscillation conditions, and also safety assessment must be better assessed for longer pacing durations, and also would like to develop real-time mesh guidance, for example, to characterize what is the ejection fraction depending on the sonication location we will test. Okay, this is the end of my presentation. I would like to thank you.
It's very interesting work. A question: do you have a model or a design how this would be used if it was external to the chest, with the ribs and the lungs and the air and things? Do you have a design or a prototype how this would be used if it was external to the patient, with the bone and the air?
Well, this is we are thinking now about making a second prototype, because this probe was designed for ablation, which is suboptimal for this application, and potentially we could imagine having something that looks like an ultrasonography for standard ultrasonography probe for intercostal, but we need to have a bit higher pressure than what can be achieved with current devices.
And do you think you can do it without without the injection?
Yes, of course, that's the objective, because I have no time to present the data, but if you inject, you have a time course that is dependent on your elimination of your contrast agent.
Quick question, please.
Oh, yeah, so very fascinating application for ultrasound, so thank you. Congratulations. You injected the sonoview in the in vivo application, so does it mean that the primary mechanism may be cavitation?
Yes, well, I have no time also to present the data, but we also monitor the cavitation activity, and when we inject, in fact, when we inject the sonoview, whatever the pulse duration, we have the same threshold in pressure, suggesting that potentially it's more cavitation when you inject. But maybe what would be nice is to better study if you're not in the cavitation regime, but maybe for longer pulse duration and lower pressure at the focus.
Fascinating work. Thank you.